Welcome back to my channel. Today we are starting with odontogenic keratocyst. This is the third part of cysts of head and neck, and let's start. As you can see in this radiograph, you will see that there is a radiolucency which is not common in normal dentition, and then you will see that there is a impacted tooth. Okay, the impacted tooth is displaced to the inferior border of the mandible, and you can see there is some root resorption present. So this is a picture of odontogenic keratocysts. So let's read about it. Synonyms of this cyst is primordial cyst, okay, and keratocystic odontogenic tumor. Now you will ask me, why is it known as tumor? Because before it was known as tumor, then it was reclassified into cyst. Okay, so we are going to read about it. 5 to 11% of all jaw cysts, it has a unique behavior of cysts. So as you know, the most common odontogenic tumor is your radicular cyst. Then you have your dentigerous cyst. This comes in third in line with the most prevalent odontogenic cyst. So it comprises for 5 to 11% of all jaw cysts and has a very unique behavior. If its recurrence is high, it can be associated with nevoid basal cell carcinoma. Okay. So nevoid basal cell carcinoma is a syndrome, also known as Gorlin syndrome. We are going to read about it in the coming slides. So KCOT, it is keratocystic odontogenic tumor. In 2005, WHO thought it to be a tumor, so it was classified as a tumor. Since it was aggressive, recurrence rate was seen, and there was mutation in PTCH, that is patch gene. We'll learn more about this gene in later slides. Okay, this was what WHO thought it to be. Robinson, he said that it arises from the enamel organ, whereas Pinborg and Hansen said that the keratocyst calumen was filled with keratin, okay, and it had a flattened epithelium and connective tissue interface. So there was epithelium and the connective tissue interface was flattened. Okay, there was no retipex or something like this. And these epithelial cells, they had a palisated nuclei which was reminiscent of the odontogenic epithelium. Okay, so they thought this to be arising from the odontogenic epithelium. Now there are a lot of schools of thought on what OKC arises, and it could arise from three things. First is dental lamina or remnant. Dental lamina remnant will be serrae, cell rest of serrae. Then it could also arise from basal cell hamartomas. Hamartoma is a formation of normal tissue in an abnormal position, right? It is a proliferation of normal tissue in an abnormal position. And then you have enamel organ. In hamartomas also there is abnormal tissue which does not fully develop. Okay. Third we come to enamel organ, which is cystic degeneration plus liquefaction of stellate reticulum. So there is cystic degeneration present in the enamel organ, and the stellate reticulum, they go degeneration before the crown formation, causing the odontogenic keratocyst. Now Philip gave us a definition which you have to remember, and I also have to. A cyst derived from remnants of dental lamina. He said it derived from the remnants of dental lamina, which is cell rest of serrae, with biological behavior similar to benign neoplasm. So we have learned about benign neoplasm, odontogenic neoplasm, right? So this cyst is derived from remnants of dental lamina, which are cell rest of serrae, with biological behavior similar to that of benign neoplasm, with a distinctive lining of 6 to 10 layers and that exhibit a basal layer of palisaded cells and a surface of corrugated parakeratinized. So what he said was that odontogenic keratocyst arises from dental remnants of dental lamina, which are cell-less of serrae, and it has a characteristic behavior similar to that of benign neoplasm. You know what is a benign neoplasm? We have learned. If you don't know, go and see my videos. Then what he said was it has a characteristic epithelial distinct lining of 6 to 10 layers that exhibit basal cell layer palisading. So you will have your lumen over here, and then you will have the basal cells. Then you will have 6 to 10 layer lining. Sorry, this is not your lumen. You will have your basal cells. Then you have your 6 to 10 layer lining, and then you will have your parakeratinized, which is corrugated in appearance. So corrugated appearance of the parakeratin, and you will have swarms of keratin present. I have added a photo to show you how it is. So here you have your epithelium, palisaded appearance. The nuclei has come onto the top surface, then the basal surface, and then you have 6 to 10 layers. Here you have stratified squamous, keratinized epitheliums, swarms of parakeratin. You will have parakeratinized epithelium. Yes, and here you have satellite cells, which you see in nevoid basal cell carcinoma. So nevoid basal cell carcinoma, this OKC will have satellite cells in the cytoplasm also. In simple OKC, you don't see this behavior. Next, we move on. We'll reach the street one this again. So, a cyst derived from remnants of dental lamina with biological behavior similar to that of benign neoplasm, with a distinct lining of 6 to 10 layers and that exhibit a basal cell layer, palisaded cells, and a surface of corrugated parakeratinization. KCOT 2005. In 2005, WHO classified it into a tumor. Why? It had regarded as a distinctive entity because of the characteristic histology it had. So proliferation kinetics and behavior, clonal loss of heterozygosity of common tissue suppressing genes, clonal deletion, mutation of genomic DNA. So central peripheral, this you don't really have to remember, I'm just telling you because first it was classified as a tumor in 2005. So if they asked you why is OKC also known as KCOT, so you should know this, just for you to know, don't have to remember. So there was central and peripheral. So the recurrence rate was very high, that is 25 to 60%, but in it could recur. But in NBCC, that is nevoid basal cell carcinoma, you had a recurrence rate which was 82%. So if you had OKC, you will have your cytoplasm will have satellite cells of OKC. So because of this, it was known as a tumor rather than a cyst. So there is another tumor, another cyst, which is OOC, orthokeratinized odontogenic cyst, where you have this one has parakeratinized and this one has orthokeratinized epithelium. This one is para, this one is ortho. Other features also there, which differences in cytokines and epithelium membrane antibodies are different of both of them, and there is CEA, which is creatine embryogenic antigen, another one which is a difference in the thus OOC, ortho-keratinized odontogenic epithelium, is less aggressive and has better prognosis than OKC. Less aggressive, better prognosis. This was before it is classified as tumor, OKC, KOC, KCOT and OOC. Next, it was reclassified because of the behavior. It was locally destructive, it was not spreading, and recurrence rate was increased, was there 25%. Histopathology, epithelial lining shows budding and proliferation in cytoplasmic connective tissue, daughter cysts. So there was local destructive and recurrence rate was high. Epithelial lining showed budding, proliferation of cytoplasmic proliferation in the connective tissue. Who was proliferating? The daughter cells, satellite cells. Mitotic figures were seen in the suprabasal layers in the cystic epithelium. So there was suprabasal layer. You will see mitotic figures. If you see this video, this photo, in some of these cells you will have, suppose this cell will have some mitotic figure as in dividing stage. Okay. So from the genetic point of view, it was reclassified in 2017 as a cyst. Okay. In genetic point of view, what happened was PTCH1 and ATSG, which is tumor suppressing gene, ATSG, which is tumor suppressing gene, involved in both the syndrome associated and sporadic case of KCOT. Syndrome associated is one you will see daughter cells in the cytoplasm and in the cytoplasm, connective tissue, and sporadic case of KCOT is when both cases you will have this gene associated, and there is chromosome 9q, 22 and 3. 22 will be region 2 and band 2, and 3 will be region 3, band 3, and 1 will be the subband. So here you will have your mutation in this case. So form a receptor complex with oncogene SMO. So the PTCH was forming a receptor complex with oncogene SMO for the SHH ligand. So it was forming a complex with SMO, and the SHH ligand was free. Okay, what does it do? Helps in implication in embryogenesis teeth. This SHH ligand has implication in embryogenesis teeth and tumor organization, regulate proliferation and regulation and differentiation. So it does help in embryogenesis. Okay. Now what happened in PTCH1 with SMO? It inhibits growth signal transduction. So the tumor will not grow. SMO is what? It is an oncogene. So if PTCH binds with SMO, it has no tumor forming. So it is inhibiting growth signal transduction. It inhibits the growth signal transduction. Okay. PTCH with SMO, which is an oncogene. But SHH, when SHH and PTCH they combine, it releases inhibition, then SMO functions as an oncogene. So when there is this mutated PTCH, it binds with SHH. Sonic hedgehog is the one. Okay, and this releases SMO free. So SMO can now function as an oncogene, so it will cause cyst. So loss of function mutation 1 of PTCH. So in mutation of PTCH, you will have loss of function and you will have gain of function in mutation of SMO. In loss of, so understood what I said? PTCH had to bind with SMO to do what? So that SHH can be regulated in a proper way, so that SMO will not cause not cause any trouble, because SMO is a oncogene. But what happened is, there is mutation in this PTCH and SMO. So in PTCH, what will it do? It will cause loss of function. And in SMO, it caused gain of function and it resulted in oncogenes. Understood? This is a kind of bit difficult to understand. I will go again. PTCH1 has what? Mutation. So before it was binding with SMO and it was inhibiting the growth signal transduction. But now it binds with SHH and the SMO is free, so SMO acts as a oncogene. This was it. Just remember this. Next we come to the clinical feature. Now is the easy part. So male is more prevalent than the female. The age is 2 to 3 years, not years, decades. The 20 to 30 decades is the peak of this cyst. So that's bimodal, and bimodal means one peak, another peak. So 20-30 years there is peak, then again 50 years another peak. Then there is site. Mandible, the ramus 70 to 75%. The mandibular ramus third molars are affected. 70 to 75%. Mandibular third molar. Remember, okay, see over here. And you see in this photo. And you see in this photo. So next is maxilla. Maxilla third molar. Okay. So multiple OKC in children, if seen, it's similar to the syndrome associated one. You will have the satellite cells into the connective tissue. Good, I did not say cytoplasm. Painless. So it is starting painless until secondary infected, and there is expansion of bone. Paresthesia of the lip and the teeth. So there is tingling sensation in the lip and the teeth. So here you have maxillary OKC and is more affected to get more susceptible to get secondary infection in the mandible because of the opening of the maxillary sinus. It has remarkable parallelism between ameloblastoma. It looks like ameloblastoma also, most like unicystic ameloblastoma. So here you have your expansion. You have an anterior posterior direction. So remember, it is a characteristic feature of anterior posterior expansion. Okay, expand in the anterior posterior direction with medullary cavity. So even the medullary cavity, mostly they are unilocular or round, and radiolucency with well defined peripheral rim. So you will have a unilocular or multilocular, but mostly unilocular, and it is well defined. You have a peripheral rim. You have scalloping variation in growth. So you have scalloping because there is variation in growth in this. You might have scalloping over here because there is variation in growth pattern. In multilocular radiolucency, larger lesions are third molar. Now this is a multilocular, whereas these were unilocular. The larger lesions are in third molar. Now the differential diagnosis could be ameloblastoma. In unilocular also the differential diagnosis could be unicystic ameloblastoma. Now if unilocular with crown of tooth involved, so there is unilocular and the crown of teeth would be involved, you might also think of a dentigerous cyst, so that you will give it as DD. Now lesions grow anterior posteriorly with little or no swelling clinically. So you cannot really make out because it's growing this way. So you will not have facial symmetry that much. So displacement in root of adjacent tooth. So you will have displacement root. Rarely you will have root resorption, but sometimes you might have root root resorption, and you will have displacement of the tooth, the inferior border. So radiographic variants, you have follicular. This is the radiographic, in the radiograph which you see. Follicular is attaches to crown and surrounds the teeth. So it attaches to the crown and surrounds the teeth. Here I don't think if you can make out, it's very not prominent, but attaches to the crown, and you have radiolucency surrounding the tooth. So other variants are replacement type, where the cyst forms in the place of a normal teeth. I did not find a picture for this. Then you have so understand that in the replacement type, this is a type of radiographic feature where the cyst forms in the place of normal teeth. Then you have envelopment type, which embraces an unerupted tooth. So in envelopment type, it embraces an unerupted tooth. So here you have envelopment type. Then it's collateral type, which will be adjacent to the root of the teeth. And you have extraneous type, which occurs in ascending ramus. Here you see away from the teeth. Anything left? Radiographic features, ascending ramus, you have envelopment, replacement, collateral. See, first one is replacement into the place of the tooth. Then you have envelopment, enveloping the tooth, enveloping the impacted tooth. Then you have extraneous, which is ascending ramus. Then you have collateral between the roots, and follicular will be fifth one. It will be like dentigerous cyst. So this is a follicular, in which there is problem in the cystic degeneration, which is combining with the enamel organ, forming this cyst. Now we come to the gross. It is thin walled, and unless it is secondarily infected, it can it's friable and gets collapsed. It's folded with and difficult to separate from bone in one piece. So it's friable. So it's very difficult to separate it from the bone. Now we come to the histology, which we have all come for. Histology. OKC wall, I just told you in the definition itself, is thin unless secondarily infected, and lining epithelium highly characteristic and show a parakeratinized epithelium. So the lining epithelium, you will have a parakeratinized epithelium, you will have small pycnotic nuclei. That is the appearance of you have certified squamous parakeratinized epithelium with pycnotic nuclei. And there is rippled and wrinkled epithelium appearance. You see in this photos. Epithelial thickness is 6 to 10 layers in thickness. Why did I place it? Basal cell layer is picket fence appearance. If you see in here, picket fence appearance will be this. So this is basal cells has a picket fence appearance in it. Okay. It's also known as a tombstone appearance. Picket fence or tombstone. So there is a tombstone. The tombstone has this design, tall columnar and hyperchromatic nuclei. There is hyperchromatic nuclei. Okay. So first the lining very thin with frequent mitotic cavity. It is neoplastic fashion. So epithelium is very thin, which it has mitotic cavity activity. What am I writing? So it has mitotic activity seen. Okay. I did remove mitotic only. Mitotic activity, neoplastic fashion. So you will have appearance to be of benign neoplasm as we saw in Phillips' definition. Mitotic, again I wrote, what is wrong with me? Mitotic activity. Okay, sorry for your loss. Inflammation is lining changes. It is non-keratinized hyperplastic plus retipex formation plus chronic inflammatory cells infiltrate. So when there is inflammation, you will have non-keratinized hyperplastic retipex formation and chronic inflammatory cell infiltrate. Okay, understood. Neutrophils will come. Then there is retipex formation of the epithelium. Retipex is this, the epithelium which you see now. There is nothing, right? It is a flat interface, but now you will see retipex into the epithelium. Then you will have hyperplastic changes, non-keratinized. It can go to parakeratinized to non-keratinized, and then can be chronic infiltratory cells such as neutrophils infiltrating the connective tissue. Connective tissue capsule, the daughter and the satellite cyst in connective tissue. That is, unicyst have 20% and epithelium islands can be 80%. So 80% could be epithelial islands which are there. So daughter cells are there in the connective tissue capsules. So without them it's 20%. So lumen is cheesy matter. It has a so here you cannot see, but here you can see, you can appreciate it as a cheesy matter. It has got keratin into it. Dysplastic epithelium present also. Dysplastic is very not appearing like an epithelium. Dysplastic. Now we come to the treatment and prognosis. Surgical excision. You will remove it, excises. Marsupialization is you create a window and you try to remove all of this from a window. Then you have enucleation and curettage, or you have Caraway solution, which is a chemical curettage. So you put this solution and you curettage the thing. Okay, this was about odontogenic keratocyst, but we still have nevoid basal cell left, so you just have a quick review of it. Nevoid basal cell carcinoma is a rare, this can be have as a laminate in the practical, so we need to learn about it. Rare inherited medical condition involving defects with multiple body systems such as skin, nervous systems, eyes, endocrine systems and bone. Okay, people with this prone to develop various cancers including common and usually non-life threatening form of non-melanoma skin cells. So they are associated with basal cell carcinoma basically. So there are many basal cell carcinoma on the face itself, you could see, and on the hands and the feet. Only 10% of this condition do not develop BCC and vast patients will. So most of the patient, that is 90% of the patient, will have basal cell carcinoma with this syndrome. It is also known as Gorlin syndrome. So if someone asks what is Gorlin syndrome, you know the answer. It is nevoid basal cell carcinoma. Then you have the clinical features. Clinical features of this is multiple basal cell carcinomas of the skin. You will have, just I told you, most of the skin, face, your hands, the neck. Then you have odontokeratosis. Why we are learning this here is because it is associated with odontogenic keratosis, which is a benign tumor of the what it was at that time. Now it is cyst. You don't know. Seen in 75% of patients and is the most common finding. 75 patients will have this. So there are usually multiple lesions found in the mandible. So you will have, satellite cysts, they are present basically and they will grow into another cyst. So they occur at a young age, that is 19 years. Right? Pits on the sole of the feet and palm of their hands, ribs and vertebrae anomalies and intracranial calcification. So this is what you see. You have pits on the soles of the feet and palms of the hand. You have rib anomalies of the vertebrae. You have kyphosis. Intracranial calcification could be valves cerebri could calcify early or later in life. In skeletal abnormalities, you have bifid ribs, kyphoscoliosis, early calcification of valves cerebri, and then restrict distinct facies such as frontal and temporal bossing. You will have frontal and temporal bossing, and then you have hypertelorism, that is the eye ka distance is a lot, and then you have mandibular prognathism, could be associated with cleft lip or palate. Microcephaly, you have a short skull, small skull. Bilateral ovarian fibromas, you could have 10% developed cardiac fibromas, and ocular defects are also present. Abnormalities are cataracts, coloboma, and microphthalmia, meningiomas. Okay, so here you have syndactyly of your fingers can also be present in this. So if you have a laminate given in the case, you will have basal cell carcinoma present on the face, syndactyly of the feet, and you will have deformities of your palms, something. You have calcification of cerebri, then you have ribs deformities, also mandibular prognathism. These are the petechiae present on your. So you have this one will summarize. Calcified cerebri, you will have ocular hypertelorism, the distance is more. Then you have odontogenic keratocyst, multiple basal cell carcinoma, then you have epidermal cyst of the skin, you might have bifid rims, and then you have palmar plantar pits. You see, this is it. That was it with the video. Thank you for a patient hearing.